ready to talk about skeleton of the hand and wrist, which includes bones of the wrist, what we call our carpal bones. There's 8 per wrist, so we would have 16, between the 2 wrists. Then you got 5 metacarpals. Those are your hand bones or palm bones. Okay. And then there's 14 finger bones called phalanges. Okay. What I'm going to do is go to my document camera like I've been doing. And we'll start by talking about the bones of the wrists. And as I said, there's 8 total, and we group them into kind of 2 rows. Okay, you've got 4 that make up what we call the proximal row, and then 4 that make up the distal row. The proximal row will be the row that is going to interact with those 2 forearm bones, mainly the radius. But that includes the scaphoid, the lunate, the trichotrum, and the pisiform. Okay. Excuse me. A lot of these are named for their shape. I remember reading a textbook. Scaphoid is a version of the word skiff, which refers to the fact that it looks like a boat. Trapezoid, you can probably guess it looks like a trapezoid. Okay. So a lot of them are Latin-based, names for shapes. Okay. As far as that goes, kind of the easiest way to kind of help keep your head straight on them is to use a mnemonic device. So I'm going to write one of those out. And if you don't remember what a mnemonic device is, hopefully me writing this out will help you. Stop letting those people touch the cadaver's hand. And it kind of fits with the theme since we're talking about the hand and wrist. And notice I capitalized the first letter of each of those words. Okay, and I wrote them 4 words across and then 4 words on a second row. Okay, the first letter of each of these corresponds to the first letter of each of the bones. Okay, so S for stop, S for scaphoid, all the way through, cadaver's hand, that would be capitate hamate. Okay, now the way that it goes is from scaphoid across to pisiform. This would be lateral to medial. Okay, remember your thumb is on the lateral side, so your scaphoid's on the thumb side, and then that means your pisiform is on the pinky side, on the medial side, and then we start back over with trapezium, trapezoid, capitate, hamate, going lateral to medial again. Okay, now we've got 2 pictures down here at the bottom, an anterior view on the left, a posterior view on the right. I want you to know the anterior view. Okay, when you kind of flip things around, and really there's no way to tell, very well what's anterior versus posterior, just looking at the 2 pictures. Okay, so between the 2, just worry about the picture on the left. Okay, I'm just gonna put a star next to each of those 8 bones. Okay, some of them are a lot easier to tell apart than others. The scaphoid's pretty easy to tell. Then you got the lunate, that one's right next to it. The trichotrum and the pisiform, those kind of get a little bit tricky. The pisiform kind of sits actually kind of more on the front side of the trichotrum. So the trichotrum looks a little small, but it's actually kind of more covered up. You can actually see it a little bit better here in the posterior view, but we can't really see the pisiform. We can just see a little piece of it there. And that's because it's more on the front side than more to the side. Okay, so we go across from thumb side to pinky side, and then we start back over with the trapezium, trapezoid. The biggest one is the capitate, and then the hamate. Okay, between those 8 bones, they kind of have a curvature that enables a lot of tendons to kind of go through here in this general area on the front side of your wrist. Coming across is a kind of fibrous band. It looks actually kind of like a band-aid. We'll talk about that structure in our next unit when we talk about muscles. But those many tendons, we got a lot of tendons that run down from our forearm into our fingers and hands to allow for the motion of those different bones to occur in those different joints. And I'm sure you've all heard of carpal tunnel before. Carpal tunnel is actually the space between the carpal bones and this fibrous band called the flexor retinaculum. When people describe carpal tunnel, more likely they're talking about carpal tunnel syndrome, where it can become narrowed due to inflammation. Very common, people that spend a lot of time typing. I imagine a lot of us will suffer from this because we're always on our phones and keeping our wrists in kind of awkward angles. Between all the 8 bones, the scaphoid is the most commonly fractured. It was one that I actually fractured when I was in high school. It's very common for like when you fall, you try to catch yourself, put your hand down, and it's a small bone, but man, it's a pain in the butt. I just spent 6 months in a cast, had to have surgery. I have a screw in it now still, so a lot of frustration from that little bone I have. Okay, moving distally, we'll now talk about the hand bones. Bones of the palm include what we call the metacarpals, which don't have a specific name, but instead have a Roman numeral to describe them. So this is, in essence, the name of this metacarpal, metacarpal 1. Then you got 2, 3, 4, and 5. Those are Roman numerals. Okay, pretty straightforward there. Okay, so just be able to identify the metacarpals, and then the phalanges will be the bones of your fingers. We have 14 of them. Each finger has 3, except for your thumb, which only has 2. Okay, they're not labeled over there, but they are here. So I'll just star them there. Pretty straightforward. Okay, now between your hand bones and your finger bones, they are long bones, even the little tiny tip of our pinky. Okay, I could label this on any one of them, but I'm just going to label this one right here because there's a nice little space right there. Okay, each of our hand and finger bones has what we call a base, a body, and a head. Okay, the base is the proximal epiphysis, the head is the distal epiphysis, the body is the diaphysis between them. Okay, now we also kind of categorize your phalanges into what we call proximal, middle, and distal. So when you have, you index through your pinky, there's 3. So there's a proximal, middle, distal, proximal, middle, distal, proximal, middle, distal. The exception to that rule, though, would be your thumb, which would only have a proximal and distal because there's only 2 in our thumb, not 3. Okay, any questions on any of your hand, wrist, finger bones? Okay, well, then that wraps us up with the upper body. You can now move down. Switch over so it's a little bit easier to see. We'll talk about our hip bones. Okay, each hip bone is called an os coxae. When together, the left and right, that is, they combine with the sacrum and form our pelvis. Okay, now the hip bones each consist of kind of 3 distinctive parts or regions. This first word here, ilium, that's not 2 L's at the beginning. It's actually I-L-I-U-M. So keep that straight when you fill it in. Then you've got the ischium and the pubis. That are the other 2 regions. Okay. Now, at the bottom, we do have one of those pictures that we can color, and I'm going to do that because I do think that helps. I've been using more of the cadaver pictures in this lecture, but I'm going to kind of take a break from that to help I really like these images. We'll start here in this top image is just where you have the whole pelvis together. Got the 2 hip bones, and then there's the sacrum and how they're connected. Okay, I'm going to color the ilium this blue color. The ischium, I'm going to go with green. Pubis, I'm going to go with red. Okay, now between the 3 images, this one I'm going to color just so you can kind of see where everything's at when it's put together. But the bottom 2 images are the images that you're going to need to know for the exam. Okay. The bottom images include a lateral view. So this is like looking on the outside of the hip. And then this would be like looking at it from like this angle from the medial side, obviously, since it's the medial view. Okay. The largest part of our hip bones is letter A, the ilium. I'm just going to kind of quickly color it in. And our top image. Sorry, I forgot to bring colored pencils, so I'm using pen, and that's not the best, but it'll work. And then down here, you can get a real appreciation for how much bigger this region is compared to the other two here in these two bottom images. Okay, so that's the ilium. Okay, that's the upper flaring portion. Then your inferior posterior portion. So going to help to be forming like the backside of the hip, and then the lower part of it. Letter B is the ischium. It has a structure that we sit on when we sit up nice and straight, like we're supposed to. In our bottom images here, it's letter B. You can see it in both images. Very nicely. And then our last region is the pubis region. Pubic or pubis is a term that you're always going to kind of think of towards like your genitalia, so like your groin area, and that's where you would find this region of your hip bones. So it's inferior, but it's also very medial and anterior. Okay. Located right between where those two hip bones meet is a structure called the pubic symphysis, or symphysis pubis, as it's labeled here. This is a piece of fibrocartilage. It's like the cartilage between our hip bone, or excuse me, between our vertebrae, the intervertebral disc that we talked about the other day. It's fibrocartilage, so it's really strong, and it prevents just like those two bones from like just crushing into one another. You can actually feel for it just above your genitalia, but I wouldn't want to do that right now, obviously. Okay. Looking at the bottom, coloring it in. Got a nice view of it in both images. Okay, so like I said, we're going to focus most of our effort here in our two bottom images, the lateral view, the medial view. Okay, on the exam, you know, if you see one of these pictures, you probably won't see them both, but you have a good chance you'll see one of them. I will tell you, if you're looking lateral or medial, if you can't tell, you know, probably the easiest thing you can do is just, you know, look for the big socket right there. That's the socket that fits the big head of our femur and forms the true hip joint. Okay. One thing, aside from being able to figure out if you're looking lateral versus medial, is to figure out if you're dealing with the front or the back of the bone, the anterior side or the posterior side. Okay. Best piece of advice I can give you is to find this very pronounced indentation, the greater sciatic notch, and I will just write this so I emphasize it, is always on the posterior side. It's always posterior. Okay. That means now you know this part of the bone is posterior, whereas this side is anterior, which is going to help you tremendously for these four iliac spines. The two on the back side are the posterior superior and the posterior inferior iliac spines. And then on the front would be the anterior inferior and the anterior superior iliac spines. Okay. Those are important muscle attachment sites. Okay. This one, when you have the hip kind of put together, the superior kind of points more forward, and it would be like right there. And if you kind of feel around where like your waistband is, you'll feel like a really kind of point to the hip. That's what you would be feeling. Okay. Now the posterior, superior, posterior, inferior aren't labeled over here on the right side in our medial view, so probably should go ahead and draw them in. I'm just going to abbreviate so I don't have to write four words out. Posterior, superior iliac spine, and then posterior, inferior iliac spine. Like I said, very important sites for muscle attachment. Okay. Other structures on the iliac region of this bone is the iliac crest. The iliac crest is this just kind of upper rim formed by the iliac bone, or iliac region, I should say, upper curving boundary of the ilium. Pretty pronounced there in the anterior view. The posterior view, or excuse me, sorry, I keep saying anterior, posterior. The medial view gives you a good view of the auricular surface, which if you think back to the other day, when we talked about the sacrum, we learned that the sacrum had an auricular surface on each side. Okay, well, the auricular surface of your hip bones matches up with the auricular surface of your sacrum, and those together create that sacroiliac joint that we talked a little bit about the other day. The SI joint, not the true shoulder, or not the true hip joint. Okay, this is just the connection that helps to form the pelvis when you add the hips to the sacrum. Okay. Now, keep in mind, we see these pictures have dotted lines. There are no true like boundary between the three regions. Okay, so it's just kind of an imaginary line going across. Okay. In our our lateral view, that gives us a good view of that big, deep cup-like depression, which is kind of a shared structure between all three regions. We call that the acetabulum. Okay, it's your hip socket, basically. We have a really pronounced ball-like head of our femur that fits directly in there, and we're going to see that on the next slide, creating a really strong foundation for our hip joint. Okay. The next structure I want to highlight is called the obturator foramen. It's not labeled here, but it's definitely visible. This is your largest foramen in the entire skeleton. Big, big hole. Okay. We have one in each hip bone, so we have two of these since everything's paired up here. But it's a big, big hole, and a lot of nerves run down through it on their way down into the legs. So that's kind of what it functions to do, I guess. Last structure is associated with the ischial region is the ischial tuberosity. I'm going to kind of darken it up a little bit. Just kind of make you see it a little bit better. That is that structure that, if you're sitting up straight, rests directly on your seat when you're in a good seated position. So your body weight has to be supported by that when you sit up nice and straight. Okay. Now there's a lot of other structures that I couldn't really get into. I'm not going to really worry about those, but there's a greater and a lesser sciatic notch. I'll just worry about the greater sciatic notch. There's some other stuff that aren't labeled here that I could draw on, but I'm not going to worry about those either. Okay, and if everybody's good with this slide, we'll jump ahead.
So if somebody gets their hip replaced, do they get that entire?
So a hip replacement, a lot of times, what the hip stays intact. It's actually more of they secure the joint, so like the connection here and the head of the femur. They do like more work to the head of the femur, if I remember correctly. It's not like you completely remove the hip and put a new one in. It's the joint, not the bone. Mm-hmm. Does that make sense? Mm-hmm. Good question. All right, now before we move on to the femur, which will be our next bone, I want to talk about just the pelvis and how it's all put together in a little bit more detail, because here is going to be an example of one of the rare instances this semester where we talk about some differences between men and women. Okay, we will discuss a lot, this semester about how muscles are bigger, bones are bigger in men, just because men are generally a little bit bigger. But for the most part, aside from being just bigger, the male and female body is pretty darn similar. Okay, an exception to that rule though is when it comes to the pelvis. Okay, now once again, the pelvis is the structure that's formed when you take the hip bones and you attach them to the sacrum and you put it all together. Okay. Inside of this pelvis, we create that pelvic cavity that we've talked about since our first lecture. But that pelvic cavity consists of actually what we call a false or greater, and then a true or lesser pelvis. And those are illustrated here with our two different colors. In pink, we show the false or greater pelvis. It's defined superiorly by the iliac crest of each bone. Remember, that's the upper flaring part. So this is the uppermost part. Okay. And then inferiorly, it's defined by what we call the pelvic brim or pelvic inlet, which they've drawn a line across here in this mid-sagittal section to show it. And then here you can see where the pink color kind of cuts off. Okay. Think of this like just the not true pelvis, hence the name, whereas the true pelvis shown in blue, this is defined superiorly by what we call the pelvic brim or pelvic inlet. And then inferiorly, it's bordered by what we call the pelvic outlet. Okay. And why this is important, because during childbirth, this space here, and you can see it like in here from our inferior views, that is the opening that a baby must pass through if a female is going through childbirth and giving birth the vaginal way instead of through a C-section. Okay. It is possible in women because women have several different features to their pelvis than men do. In all different dimensions, the female pelvis is going to be wider. Okay. Looking at our different images, we've got females on the left and then males on the right. Looking at like the brim and or inlet, it's a little bit more tight versus a little bit wider. The false pelvis is even wider in females. We can really get appreciation for the difference here in these inferior views when we can see into that cavity. They're wider, but they're also front to back wider as well. Okay, so that's a fantastic feature. Females have a wider subpubic angle or pubic arch, as it's labeled down here. It's greater than 90 degrees, or even in some cases greater than 100 degrees. Whereas men, it's much smaller, much smaller. Female pelvis, as I mentioned, has a broader true and false pelvis than males. And the sacrum and the coccyx actually kind of tilt more backwards in women than they do in men. So that opens up things a little bit more and makes childbirth more possible. Now, aside from that, during the 9 months of pregnancy, as a female gets more and more advanced towards delivery, a lot of changes occur, like those point where the two hip bones meet, where that pubic symphysis is. The hips actually separate a little bit, and that can lead to pain. I talked the other day about like SI pain, when the SI joint kind of is put under stress, and a lot of that probably is because of what's happening to these hip bones. It's all hormonally controlled, and very amazing. Childbirth is an incredible thing that ladies do. Okay, as far as the pictures go, don't worry about it. You got enough to worry about as far as pictures go. So just know the information on this slide. All right. Moving on, we will then now talk about the femur, which is our thigh bone that I've been referencing a little bit here since we've been talking about the hips. Longest, strongest bone in the body. And since we've got room and there's not a lot to talk about, we'll go ahead and talk about the patella on this page as well. Okay, nothing too crazy there. So it should be able to be easy peasy. Okay. Let's just go ahead and start by talking about the patella and just get it out of the way. Okay, it is commonly called our kneecap. Okay, it is roughly triangular in shape. You can kind of hopefully appreciate the triangular shape to it. Embedded in the tendon or quadriceps femoris tendon, or quadriceps femoris muscle, excuse me, which is the muscle that we call our quads. Okay. On the back side are these two what we call articular facets, and they sit right up against this patellar surface of the femur and enable them to kind of slip and slide over one another. But as far as the exam goes, I'm not going to worry about knowing those or the base or apex. Just be able to identify that these two images are showing the patella, and that's kind of the main takeaway. Nothing too crazy. You got enough to worry about for things like the femur. Now, the femur we'll start at the top and work our way down, just kind of like what we did with some of those arm bones. Most prominent feature of the femur, aside just from its huge size and length, is its very pronounced head. Okay, very ball-like head. Okay, which is fantastic because, as we just talked about, it fits right in that cup-like depression of your hip bones called the acetabulum, creating a really strong joint. Okay. Now you can't see it in either of these images, which on the left we've got an anterior view, on the right we've got a posterior view, which is why I've included this medial view to show you the structure. I'm just going to darken it in. Don't worry about this bottom image. The only reason I included it is to show this off. But this structure is called the fovea capitis. It's a small central depression or pit on the femoral head and is an attachment site for ligaments. So you can't see it. And you can maybe kind of see a little bit of that indentation right there, but you really have to turn the femur sideways to look at it and see it. Okay. What we're going to find is that there's a lot of similarities between this bone and the humerus. You know, your humerus was the upper arm bone. It had a rounded head. Humerus also had a neck. So does your femur. Okay. Unlike the humerus, which had a surgical neck and an anatomical neck, the femur just has a neck. Okay. So you don't really need to worry about it and kind of anything but just neck. Okay. It's just a constricted portion. And I've talked a little bit about this before, but this is where a lot of times a fracture occurs in elderly, you know, especially elderly females when they slip and fall and grandma breaks her hip. She's truly not breaking her hip. She's breaking her leg. It's just up there by the hip joint. Okay. Now, right there by the head and neck are two very prominent projections, what we call the greater and the lesser trochanters. Very important sites for muscle attachment. Okay. Things like your hamstrings and your you know, your butt muscles, your quads and stuff like that will touch to some of these different things up there by your hips. Okay. Greater trochanter actually is this actually going to create the widest part of our lower body. And so basically after that, we all just kind of, you know, turn inward. So, you know, like next time you stand up and look in the mirror, you can kind of see that greater trochanter pushing outward, and then look at the rest of your body. It's, you know, tilted more inward. Okay. Greater trochanter, very similar to the greater tubercle. Remember your humerus had a tubercle, a greater and lesser. Here we have trochanters, which are just a little bit bigger. Okay. The lesser trochanter kind of points more medially, whereas the greater trochanter points more laterally. Okay. Now on the anterior side, connecting those two, and I'm just going to kind of just draw a line across to represent it, is the intertrochanteric line. Okay, just kind of an oblique angle there connecting the two. Whereas on the back side, a much more prominent structure is the intertrochanteric crest. Okay, so it's just more like a ridge than just kind of a line. So that's where those names come from. Okay. I'm going to skip the gluteal tuberosity. It's just so subtle that there's not a whole lot to really see there. And so it would be hard to kind of identify. Next thing I'm going to highlight, I'm actually going to kind of darken it in. Pretty prominent structure called the linea aspera. Linea aspera is another important muscle attachment site. This would be where some of your hamstring muscles attach, since this is where the, you know, the back of the leg would be. And that's where your hamstrings are. Okay. Rest of the structure is going to be down here by your knee joint. Okay, so I'm gonna zoom in just a little bit. Okay, first thing, I've already talked about this, so I'll go ahead and highlight it, is the patellar surface. Patellar surface is also going to go by a structure that we talked about the other day, that your humerus has the trochlea. Okay, remember the trochlea was the part of your humerus where the trochlear notch, which was that like U-shaped structure where those come together and form your elbow. Okay, but this is just the indentation on the front side where the patella is able to slip inside. So that's why patellar surface is perfectly fine for knowing. So that's on the anterior side. On the back side, you'll see a more deep depression, what's called the intercondylar fossa. Okay, now we know what inter means, between. Okay, condylar is because we're talking about these structures here, these oval shaped round knobs called condyles. Okay, the intercondylar fossa is an important indentation where you're going to find ligaments like the ACL and the PCL, which you may have heard of before. Imagine everybody's heard of the ACL before. Okay, now I'm going to go ahead and highlight the two condyles, medial and lateral. Between the two pictures, though, you can basically just like ignore this line pointing over here to the anterior view. Same thing. Don't worry about the image on the anterior view for lateral condyle or the line pointing to it, because really the best way to show the condyles is in this backside view. These condyles are the knobs that sit on top of the condyles of the tibia. Okay, and that's going to create the true knee joint, where we can then bend our knee, flex our knee, or straighten it. Okay, now if you can't tell, really there's no discernible difference between medial and lateral just by looking at them. Just go back up to the top and find the head. Okay, the head is always going to point that direction because it has to connect into your hip. Okay, so your head is medial, and if you just go down on that same side, that's going to help you know that this is the medial condyle, and therefore this has to be the lateral condyle. Does that make sense? Okay. Now, not to be confused with the two condyles are the two epicondyles. Okay, same thing. We've got medial on the medial side, lateral on the lateral side. Okay, these are bumps kind of on the outside of the bone. Okay, whereas condyles are on the end of the bone. Okay, so when we talk about epicondyles, are on the sides, whereas condyles are on the ends of the bones. Okay, we saw epicondyles in the humerus the other day. Remember, we felt for those two bumps on the inside and the outside of the elbow. Okay, these are important attachment sites for ligaments. Okay, not the ACL and PCL, it's instead MCL and the LCL. So we're going to talk about those in the next lecture when we start talking about joints.
And that was the medial epicondyle?
Medial and the lateral. Okay, just these bumps on the sides. Basically, if you kind of imagine it, there's a ligament that goes from here down, and then there's a ligament that goes from here down to your two lower leg bones. And those help with creating a stable knee joint as well. As far as the other structure that's labeled there, the adductor tubercle, it's too hard to kind of tell anything different from that in the medial epicondyle, so don't worry about it. All right, any questions on the femur or the patella? Okay, let's talk tibia and fibula. So we saw a lot of similarities between your upper arm and your upper leg. We're going to see a lot of similarities between your forearm and your lower leg now. Okay, your forearm, where the ulna and radius are located, are two bones. We have two bones in our lower leg. Okay, medial tibia, lateral fibula. Okay, notice the name of those is tibia, fibula, not tibula, not fibia. Okay, that has always been a pet peeve of mine. I always just call them tib and fib for short. If it helps you, the easiest way to remember fibula, which ends with LA, think LA for fibula. LA begins the word lateral. So if you combine those words, you can just say fibulateral to help you remember. Okay. Between the two, the tibia is much stronger, much thicker than the thinner fibula. I had a student, she told me she was able to remember tubby tib because it's fatter, and then fine fib. Okay. And then just like in our forearm, between those two bones, we don't have a picture to show it, okay, would be what we call the interosseous membrane, a long sheet of collagen, and it just connects and supports those two bones to one another. Okay, like what we had with the ulna and the radius. There's one kind of more complicated bone. There's one a little bit simpler. Okay, we'll start with the simpler, the fibula, which once again provides stability, and it's a lot skinnier. That's why it's fairly common for people to have, like, when they fracture their fibula, which you'll make sure you can identify it, they can actually a lot of times walk without, too much trouble, even if they have a broken leg. Just because, I mean, look, it doesn't have a whole lot of responsibility for weight bearing purposes like your tibia does. Okay. My wife broke hers, but it was down here by the ankle, so she had to have surgery and was in a boot and crutches for quite a while. That was quite a while though, so she's all fine now. The two things that I want you to know about the fibula just are the head and this structure at the bottom end of it, what we call the lateral malleolus. Okay, if you ever wondered what the two knobs are down at your ankle, one on the outside, one on the inside, the one on the outside is this lateral malleolus. Okay, the one on the inside is from the tibia, and I'll just go ahead and highlight it because it's one of the structures I want you to know. That's the medial malleolus. Okay, kind of like what we saw with the styloid processes of the ulna and radius. They kind of come down and they kind of just cradle around our ankle bones, and they just help to provide stability to that ankle joint. Okay, so fibula quite a bit easier than the tibia. Okay, tibia much more difficult. Okay, it's the one that helps to form the true knee joint between it and the femur that we just talked about. Okay, we see some structure right away that we just talked about with the femur, what we call condyles, and what we also have are epicondyles. Now, the way that this image is labeled actually kind of drives me nuts. Okay, you can see they've got the lateral and the medial condyles labeled, and they're kind of pointing to the sides of the bone. Okay, well, that's not the way that I would actually do it if I were in charge. So what I'm going to do is I'm going to change it, and I want you to know where they have them labeled now as epicondyles. Because just like with the femur, epicondyles are on the sides of the bones, and that's where those arrows are pointing. Okay, those are important attachment sites. For example, the medial epicondyle of your tibia is where the MCL connects coming down from the femur. So where are the condyles? Well, they're on the top of the bone. You can see really nicely here in both images how it's flat on top. Okay, that entire flat structure on top of the bone is sometimes referred to as a tibial plateau. Think of like geography, a plateau is like a hill, but that's flat on top, like a flat top. Okay, so how I always label it is I just kind of draw an arrow down directly like that to those flat areas. If you're looking on the medial side, this would be the medial condyle, and that would be the lateral condyle. Same thing over here. Lateral condyle, medial condyle. Now, if you can't figure out medial lateral, there's kind of a couple different ways to figure it out. Okay, if you look and find the fibula, because if you have these pictures on the exam or one of these pictures, it'll be both bones together. Well, the fibula is always lateral, so you know this side of the bone is lateral. Okay, or if you don't want to do that, just go down to the ankle and find the structure called the medial malleolus. So you know this side of the bone is medial. If you just go straight up from there, now you know right on top, medial condyle, medial epicondyle. Does that make sense? Okay. Now in between the two condyles, kind of see it right here. They almost look like two little mountains. Those are called the intercondylar eminence. An important site where that ACL, MCL stuff is able to connect to the tib. Okay, on the front side of the femur, very prominent bump, and you can feel this. I was just kind of darkening it in to really show it. If you go and put your hand right on the front side of your knee, you'll feel your patella, your kneecap, and just below that, you'll feel the soft patellar tendon. And then just below that, you'll feel a knob. Okay. That knob is called the tibial tuberosity, and that's where that patellar tendon connects. The patellar tendon connects the patella to your tibia by way of this tibial tuberosity. Okay. You continue to run your hand down the front of your leg. About halfway down, what we commonly call our shin is a very pronounced structure. It goes by anterior border or crest. Like I said, we commonly just call this our shin. That's an S, not an 8. Sorry. Handwriting's not the best. Okay, once again, then down distally, you have the medial malleolus. There is one last thing I want you to highlight, visible here in our posterior view. It's called the fibular notch. And is exactly what its name implies. It's a notch, basically where the fib connects right there. And it's going to have some ligaments and whatnot to help hold those bones together, just providing stability. You can kind of see how it's like indented right here. That probably would be another place where you could label it, but it's labeled over here and that's perfectly fine. Good enough. And then remember, you got that interosseous membrane in between those, just connecting them. We'll see picture in our next lecture of that. So you'll get a good feel for it. So that brings us to our final set of bones, just like what we did with the hand, the wrist, and the ankle, or hand, wrist, and fingers. We'll just kind of talk about tarsals, metatarsals, and phalanges all in one slide. We have 7 tarsal bones. There was 8 carpal bones, so there's only 7 tarsals. These help form our ankle. It includes a singular talus, a calcaneus, navicular, a cuboid, and then 3 cuneiforms. There's a first, a second, and a third. I just really don't even care about, the different way. Just as cuneiforms is perfectly fine. Then you got 5 metatarsals and 14 phalanges, kind of the same situation. Each is going to have a base, shaft or body, and a head. And we give Roman numerals to the metatarsals 1 through 5, as you can see in the picture. Go ahead and, I guess there's nothing right at the bottom, is there? All right, so what we'll do, let's go back to my document camera here. Same thing, what I've been doing, I'm going to highlight what you want to know. So we've got a superior view that's looking at the top of the foot and ankle, and then this is looking at the bottom of the foot and ankle. Okay, first bone is the calcaneus. So go ahead and highlight. It's not the first one listed, but I'll go ahead and highlight it. So I'll just start at the top. That is your heel bone. It's the longest and strongest. It has to be the one that supports body weight. When you think about when you step, generally you step heel first. So it's got a kind of an odd shape. It's one that falls in that irregular shape. It really doesn't do it justice seeing it from above or below. If you see it from the side, which is what you can see at the bottom, you can kind of see it's kind of got a weird shape to it. Okay. The talus sits above that, so you can actually see it quite a bit better in the top view. That's the one that articulates with both the tibia and the fibula to form the talocrural joint. The talocrural joint is called that. Fancily, it's more commonly what we call our ankle. Okay. We call it the talocrural because it's between the talus, talo, and then crural. Remember, that's just a fancy word for lower leg. Okay, so that's where that term comes from. Okay, then you've got the navicular. The navicular sits just in front of the talus on the medial side. Remember, it's easy to tell big toe versus little toe. So this is the big toe. This has to be medial because your big toe is medial. Okay, that's where you find the navicular, whereas the cuboid is lateral. Okay, cuboid gets its name because it's kind of cube shaped. And then kind of in between and in front of those are the three cuneiforms. You just have to know them, like I said, as cuneiforms. Don't worry about first, second, or third, or medial, intermediate, lateral. Just cuneiform is fine. Then you have the 5 metatarsals. Once again, just Roman numerals 1 through 5. And then the phalanges. Now I could do the same thing I did with the hand and fingers, where you can go base, body, head, proximal, middle, distal, but it's the same thing. And so I'm not going to even worry about that. In that inferior view, we can see a couple of sesamoid bones, like those that we mentioned. Remember, those are going to develop in certain tendons, and in this case, on the bottom of the foot. Last thing I want to talk about are the arches of your foot and ankle. These 2 arches support the weight of our body, include a 2-part longitudinal arch, and the 2 parts are the medial and the lateral arch. Okay, they extend from the calcaneus and at the heads of the metatarsals. Okay, if you kind of think of it, they kind of make a V. If I were to draw, I'm not going to. They go from here to the big toe. That would be the medial part, and then if it goes to the pinky toe side, that would be the lateral part. Okay, and then crisscrossing horizontally would be the transverse arch. Okay, formed by the navicular, the 3 cuneiforms, and the bases of the 5 metatarsals. Okay, now the function of these is to provide spring and leverage to the foot when walking. They flex when body weight is applied. Unfortunately, there are situations where the arches can be either too much or too little. Pretty straightforward, I would think, what flat foot is, where the foot is more flattened because the arches have decreased or fallen. Very common in athletes, especially like runners and jumpers, because just putting all that weight down on the body repetitively pushes down. Opposite of that is clawfoot, where there's too much arch, and there's a variety of reasons that causes or is caused. There's a fancier term for both of those: pes planus, pes pedis, but flat foot, clawfoot's perfectly fine for this class. Great thing about arch issues is they're pretty easily treated anymore with orthotics, which is where you go to a specialist. They give you an insert into your shoe, and it either makes the arch greater or helps kind of alleviate it if you have too much of an arch. So fairly easy, and you can transfer those from shoe to shoe, which is very handy. Okay, any questions on the appendicular?